Going to jump right in. Remember last time we were talking about minimally invasive surgery, like the advantages, disadvantages of it, and then the type of instrumentation that you'll see. It's all the same, right? We're still using these like retractors and scissors, forceps, clamps and stuff in terms of clips and staples, but they're all going to be like those long telescopic versions, right? Because we're still performing the same surgery, right? We're still doing and trying to accomplish the same thing, whether we're repairing something, removing something, making an incision into something, whatever it is, we're still accomplishing the same thing. So a lot of those instruments are going to look the same when you're looking at the tips of the instruments. The actual length and shape of that instrument may be a little bit different, but that's because of the way that we have to use it. But its tip is going to be the same as the other stuff that we use whenever we're doing an open procedure. Let's see there. Everybody's just getting home from lab. Be prepared for that for next term when you're with Miss Kimbleton in the lab. She tends to go right up to 12 o'clock. So, I like to try and give you guys a little bit of time to maybe clean up or something like that, kind of break things down. But she likes to go right up to the time. Hang on just 1 second. Sorry about that. That's that again. There we go. So then we get into some scopes that are like kind of specialty scopes. Right? You have your endoscopes that are typically like flexible. These are your colonoscopes, your EGD scopes looking down the esophagus. These are the scopes that are used mainly in the endoscopy department. Then you also have your resectoscope. It's rigid, which means that it's not flexible, right? You can't bend it. Typically used in urology. There is also a resectoscope that you can use in GYN when doing like hysteroscopies, operative hysteroscopies, and things like that. Usually you have that cutting loop that's attached to it. You guys will learn more about that when you do the urology section, GU. But that cutting loop, I don't think you guys have seen it in the lab yet. But it's a cautery, and it's designed to hook to the resectoscope, and then you extend that out, and the loop itself is what heats up. And then as you drag it back, you're cutting through tissue. So you're cutting like strips of tissue off. Typically, the resectoscope is used when resecting the prostate. It's a procedure called a transurethral resection of the prostate, or TURP. You can also use that the resectoscope to resect bladder tumors within the bladder. So that one's a TURBT, transurethral resection of a bladder tumor. The resectoscope will get inserted directly into the urethra and then track up into the bladder or to the area where the prostate surrounds the urethra. And they'll resect off strips of that to kind of shrink its size, because the prostate is enlarged so much that it's causing retention of urine in the bladder. So we need to go in and scrape off and resect some of that tissue to allow that bladder, neck, and everything to open fully and allow for complete drainage. Get those people who are coming in. Then you have insufflation for laparoscopy. This is also referred to as a pneumoperitoneum, meaning you have air in the peritoneal cavity. You guys have seen this. I showed this to you in lab, and some of you worked with Ms. Kimbleton today. You can be done with a Barrius needle, right, where you stick the needle in, and then you do the saline test, where you put a 10 cc syringe of saline on the top, and then they'll inject that saline into that Barrius needle and make sure that the needle actually drains. If the needle doesn't drain, or it's draining slowly, then you may not actually be into the abdominal cavity yet. And the reason we do that saline test is to make sure we're in before we hook up air. Because if we're not in, now we're going to push that air into tissue, and we may start separating like muscle from fascia and things like that, because that air is going to go in there and cause pressure and try to divide areas, because it wants to fill in space. Remember, we're making those small stab incisions with what kind of blade? What surgical blade do we use to make stab incisions with?
11.
Yes, good job. An 11 blade, right? Because that's the one that looks most like a knife, right? Like a switchblade or something that you can stick somebody with. Oh, that's right. So I'm going to mark this one good. Okay. And then this picture down here, and you've seen it in the lab, this is your insufflation tubing that gets attached to the Barrius needle and actually pumps the CO2 into the abdominal cavity, causing it to distend, like you see in picture B here. And remember, this is your filter for the insufflation tubing. The end that the filter is closest to is the end that you always pass off of the field. And then keep this end for yourself, or for up on the field. Right? So if we're working in like the abdominal cavity, the thoracic cavity, I think abdominal and thoracic cavities, we're insufflating with air. When we're working inside of a joint or inside of a hollow organ, like a bladder or a uterus, then we're going to be using fluid or continuous irrigation. We can use, glycine, mannitol, sorbitol, or even normal saline. Typically, when we're working in the bladder, we can use normal saline if we're not doing anything operative, which means we're not using the resectoscope. We're not cutting away tissue, right? We can use saline. We can get away with saline. Saline's fine. Once we start doing things where we're going to be using the Bovie, now we need to change up with these solutions, because we can't have that solution perpetuating the electricity into the body, right, from the Bovie that we're using. We need it to stay within that area and not spread. So that's why we change up the irrigation that we use in the bladder. Typically for arthroscopies, you're using saline. And then hysteroscopies, you can start with saline and then switch it up again if you're doing something operative with a bovie or something like that with the electric artery. The thing with whenever working inside a hollow organ like the bladder or the uterus, we have to keep very strict watch on input and output. Right? We have to make sure that however much fluid we put in has also come out, especially for the uterus. Because if we leave fluid inside the uterus, it's going to want to absorb it and then put it into the bloodstream for that filtration process to happen in the kidney. We don't want to do that because now we're increasing the patient's fluid in their vascular system, which therefore is going to increase their blood pressure, which could then cause bleeding because they just had surgery done. Right? So a lot of those blood vessels and things that we cauterized are still, have that eschar on it, and that may be enough to stop it bleeding at that moment. But if we take their blood pressure and make it go up, now there's more pressure in those blood vessels that's pushing against that like scab or the eschar that's on the outside of where we use the bovie on it. And it could be enough to overcome and push that eschar off. And then now you have active bleeding again. This is that balloon dissection. Right? These are the pictures of it when doing an inguinal hernia. So they go in, and when they inflate the balloon will actually spread that area and show you Hasselbeck's triangle. And then you can go in and work on your indirect or direct hernia. And then as far as hemostasis goes, we can use cautery or the electrosurgical unit, right? We can use sutures. We can use clips. We can use the harmonic scalpel or the ligature. Right? All different kinds of ways to do hemostasis, but we're accomplishing the same thing as we did with clamp, cut, tie. We're maintaining that hemostasis. Trocar cannulas. We've kind of gone over this in the lab. Remember, a trocar is the cannula with the obturator in it. So those two pieces put together makes a trocar. When you remove the inner piece, that's the obturator, and then the cannula. The cannula is what gets left in the patient so that we can create that port system for putting in and out instrumentation and our scopes. Right? But this trocar cannula, or the trocar system, is used for laparoscopy, arthroscopy, thoracoscopy, not for hysteroscopy or for cystoscopy, because we're going through already a natural opening. There are cannulas and stuff, but we don't leave those in the patient. They're all connected to the scope, and we put the whole thing in and out as we work. And then those cannulas for hysteroscopy and cystoscopy also have little side channels so we can feed instruments in, and laser fibers and stent wires and stents and things like that in that we need to work in those areas. Some of them, most of the trocars you're going to find out there will be disposable. The reusable ones you'll see for the robot procedures, because they have very specific cannulas that actually connect to the robot arm itself to kind of give the robot arm, kind of stability and a focal point to kind of work off of. But you have some that are reposable, which means you can kind of change their shape a little bit, the angle. And then you have all different kinds of sizes, right? You got 5 millimeter ones, 10 millimeter ones, 12 millimeter, 15 millimeter. I believe there's even a 20 millimeter. Excuse me. And when we're talking the size, we're not talking its length. We're talking its diameter. How big of an instrument can we fit inside that cannula, right? If it's a 5 millimeter one, then we're only fitting things that are 5 millimeters in diameter and less. If it's a 20 millimeter, then we can fit anything up to 20 millimeters in there, which means we can put a 5 millimeter instrument in there. The hole is big enough. Just the problem is that you're going to kind of like break the seal to put it in, because there's seals that, especially near the head of the trocar, little rubber seals inside, and they're like why can't I think of the word? Like in your heart, valves in your heart, right? So that fluid can go in one direction, but it can't come back the other way. It's the same thing like that in the trocar to prevent leakage of air. But you need the instrument that you put in should be the same size as the diameter of that trocar, so that as you go through, everything is sealed. You don't get leakage past the instrument. That can happen if you're putting a smaller instrument inside of a big trocar or a big cannula, because that you're not filling that entire space, so that the seal has little leaks on the side. So you could be losing some of your insufflation while having that smaller instrument in the bigger trocar. Typically 5 millimeter, if you're using all 5 millimeter ports, you're probably working on a pediatric patient. You could have some 5 millimeter ports with some 10 millimeter ports. That's usually for an adult. And then usually your 15 to 20 millimeter ports are for bariatric patients, or if you're needing to pull out a large specimen, like you resected the bowel. Typically for bowel, they'll make like a mini laparotomy incision, and you'll pull it out of that. But if you're taking out like at the spleen, or like the left lobe of the liver, the pancreas, something like that, and you're putting it in the bag, you may need like a 15 to 20 millimeter cannula to be able to remove the bag, the specimen bag, through that port. Placement is going to be dependent upon the procedure we're doing. Surgeons like to usually try to triangulate. So they're going to put ports or cannulas around the area, so that they can, as they go in with their instruments, then they can just angle and go right to that area. They never want to put a port directly over a spot, because then you can only come straight down at the thing you're trying to grab. You can't come at it from like an angle. So you're always working with your hand way up in the air. You want it to be a little off center, so that you can kind of drop your hand. You can be in a more comfortable position with your shoulders and your arms and your back and stuff like that. That tissue expansion, right? We've talked about this, happens through that insufflation or through using the irrigation. Right? If you're using insufflation, well, either way, what you're accomplishing is what's called distension. You're distending the abdomen. You're inflating it with air. In a joint, you're distending that joint. You're inflating that joint with fluid. Right? And then we talked about the balloon expansion, just for separation of tissues, things like that. Most of the time, you'll see it used for inguinal hernias. Specimen retrieval, right? The picture you see there, that's an Indo-Catch bag. It'll come, the way that it'll come is this bag and everything is actually tucked up inside the silver metal piece that you see here. You'll put all of that in, and then as you deploy the bag, all of this will come out from inside of there and then open up for you like this. And you shove your specimen in there, and then when you pull this back, it'll cinch this closed. It won't pull it all back up into here because it can't. Right? It would be too big of a thing to shove back up. But once you hold it shut, then it'll close this bag here, and there's like a string attached to it, and then you can pull the whole thing out and bring it out that way. You can pull out specimens whole like this, or you can morselize them, which means you're cutting them into smaller pieces and taking them out piece by piece. You're making them into little morsels. Right? Or you can do tissue shaving, where you're kind of cutting it into strips and then pulling out the strips. Right? Or you can bring it out whole in a bag. Typically gallbladders, the appendix, like an ovarian cyst, teratomas, things that are kind of small enough to go into that bag usually come out whole. If you're doing, like a laparoscopic hysterectomy, they'll pull that out through the vaginal canal most often if you're doing it laparoscopically. Only because you do have to cut the cervix, because you're cutting the uterus away from the cervix. So as soon as you cut in the cervix, you now have an opening between the vaginal canal and the pelvic cavity. So it's already open. You can just reach in that way and pull it out through the vaginal canal, and then close the cuff, is what they call it. Justenia is saying that she's had a LAVH, a laparoscopic assisted vaginal hysterectomy. So what they do is they go in with the scope through the abdomen, and they cut off all the blood supply. Right? They take out the round ligament, broad ligament, all the blood vessels, all that stuff, and then cut through the cervix, and then pull out the uterus from below, and then through the laparoscopic will suture that cuff closed. So now you no longer have communication or an opening from the outside world and to inside the pelvic cavity. Much better than trying to, because if you're doing it laparoscopically, you're trying to, better recovery for the patient, right? They don't have to be, out of work for so long and heal for so long. And there's not as much, pain associated with. Well, if you're doing it laparoscopically, you get all that stuff freed up, and you don't pull it out from below, you want to pull it out from above. You're either going to have to morselize it, cut it into smaller pieces, or you're going to have to make another incision, like what they call a mini laparotomy, because you won't have to make the full midline. You just have to make it big enough to be able to pull the specimen out. Well, if there's already a way to pull it out from below without having to make another incision, you want to go with that way. Because if once you make that mini lap, now you've just defeated the purpose of doing it laparoscopically. If you were going to make this incision, you should have made that incision from the beginning, dealt with what you were going to deal with, and then close that incision. But we already talked about insulation. This is insulation. So all of your instruments that you can hook the cautery up to, and I'll make sure that Ms. Kimbleton shows you guys this. And I think I have some instruments on here that I can point to spot. But some of the instruments will have this little metal rod kind of sticking off of it. This is a place where you can connect your cautery to. You connect a cord to that and have it go and plug in to the Bovie machine. All of those instruments have to have an outer insulation on them to prevent this coupling, whether it's direct or capacitative, right? If a piece of that insulation is cracked or broken off or something like that, as that electrical current flows through that instrument, it's always looking for the path of least resistance. And typically, it's supposed to travel all the way down and come out at the tip. But if you have a crack or a break in that insulation somewhere, some of that electrical current's going to go out through that area because that's the closest one. That's where it always wants to go. Well, if that little crack or tear in that insulation happens to be touching up against another organ or the abdominal wall or something like that, that's where you're going to get this coupling effect, and you're going to get a burn to an area or to tissue that you weren't, that you didn't want to, right? That you weren't trying to. You were grabbing whatever you needed to burn with the tip, and you might get some burn at that tip, but you're also going to get burn off the side and get these stray currents that are going out, right? And the Bovie machine is not going to alarm to you that any of this is going on, because what it is monitoring is that the current is going through, and it's going through the instrument, and it's going through the patient, and it's getting to the dispersive electrode or the grounding pad, and then coming back to the box. That's all it's monitoring. Is, hey, is all of that still going on? Okay, good. Well, some of it is coming off to the side and burning a place you didn't want to get burned. So that's why we need to inspect our instruments before the surgery starts. Just give them like a once over. Look them down. Make sure you don't see any metal showing, that there aren't any cracks and stuff like that. If there is, either get a whole new tray or get another instrument and peel pack that replaces that one. Ways to reduce the risk, right? Watching, making sure that what you see on the screen is getting burned, looking for any, stray burns and things like that inside the patient while we're working. Inspecting those instruments, using the right cannula. You're not trying to shove, a 10 millimeter instrument into a 5 millimeter port, something like that, right? Is the power setting correct on the machine itself? Was it reprocessed properly? Right? Or while you're reprocessing, you're checking the same insulations and stuff like that. So you're not sterilizing a tray with bad instrumentation in it. Is there a problem with the cord? Is it getting pinched or something like that, right? Is there a kink or a knot? One of the cool things, I used to think that there was never really a problem with wrapping your Bovie cord around like an instrument, just to kind of secure it up on the field. Until we had an in-service where somebody brought in, like the lights they put up in the ceiling lights, the big long tube-like lights. He had one of those, fluorescent light. Right? And he took the Bovie, plugged it in, he hooked up his grounding pad, all that stuff, made sure the circuit was complete so it would operate. And then he took the cord of the actual Bovie and wrapped it around that fluorescent light bulb, and then just pushed the button that started the Bovie. The light lit up just from kind of the electrical currents that are leaking out of the cord itself. And you can imagine that you wrap that cord around a metal instrument. Now that metal instrument could heat up because it's got electricity going through it, and you could either cause a hole in the drape by burning it, fire, or injury to the patient. And then always try to avoid any kind of wet surfaces with any electrical cord. It's just a good rule of thumb. There may be microscopic cracks or something in the insulation of the outside of that cord. The water gets in, you short out, or potentially start a fire.
I got a question.
Yes.
So you say not to wrap any instruments around the bovie and whatnot because of the electrical current that might be coming off and it might heat up, correct?
Yes.
All right. So what's the difference between, let's say, when we're having, remember how we have the Alice clamped onto the bovie cord and the suction cord? Why is that not a problem? Why do we do
So,
that if?
so that clamp isn't actually on the cords; it's only on the drape. So the cord itself isn't touching the metal of the clamp. Um, what I'm talking about, I'm trying to check see if I've got an instrument in here. Is sometimes what you'll see out there in the field is instead of them incorporating that cord, into the drape and then you tenting the drape over and clamping the drape, they're going to take a little bit of that bovie cord and kind of create a loop out of it, and they'll feed it through one of the rings of your Alice clamp, and then take the loop in and catch the other ring so that it holds it. Now that's where you're taking that cord and actually wrapping it onto the metal of the instrument. And that's where it can cause a burn in the drape or a burn to the patient. Does that make more sense?
Yeah, so just basically don't wrap it around itself.
Yes.
But like having the one cord, like having it one go through one time, it's not a bad deal.
Yeah, I'll show you guys in lab. So like this is the finger ring, right, of your instrument. And what they'll do with the cord is they're going to take the cord like this, and they're going to pass it through one side of your ringed instrument, and on the other ring, on the other side, they're going to take that loop and hook it around it like this. And what that's doing is it's just keeping that slack that you have to keep for the cord from falling off of the field. But in doing that and wrapping that cord around any of that metal stuff, you're now getting that transference of electricity to the instrument itself. Now, granted, it's not the full power of the electricity that's going through the bovie, but it is some. And continued use of the bovie and stuff, it's just going to pump more and more electricity through that, uh, causing that risk. But you got some other wireless risk reduction. But you have other tools that can be used laparoscopically, right? You have your harmonic scalpels that use the like ultrasonic type energies, right? You have bipolar that can the bipolar high frequency bipolar is more like your ligature that'll go onto it and coagulate and cut the tissue in one shot, right? You can use lasers. Most often, lasers. Most place you'll probably see the laser getting used is in urology when doing kidney stones. And then you also have ways that you can suture laparoscopically with the endo stitch, and then what else? For like shoulder repairs, rotator cuffs, things like that. There's suture anchors and different tissue passers and things like that that you can put into the joint that'll help you repair like tears and stuff. Um, the extracorporeal and intracorporeal, this is referring to a suture technique, most specifically where you actually tie your knot. So if we're talking extracorporeal, does anyone know what that word means?
Outside of the body.
Outside of the body, right? Which means that you're going to have the strings of whatever suture you're using are going to be hanging outside of the cannula. And you're actually going to tie your knot outside of the cannula. And now you need a special instrument called a knot pusher, which is it's just a long metal rod, and it's got like a little divot at the tip so that you can put it onto one of the strings and actually slide the knot down and then inside the body. And then you watch on the monitor as you tighten down that knot. And then you do it again, you tie another knot, and then put the knot pusher on again and slide it down until you've got enough knots on there that'll hold it. Intracorporeal means now we're going to tie that knot inside the body. So, which one do you think we're doing with our hands?
Say that again.
So, out of these two examples, extracorporeal and intracorporeal, which one do you think we're actually tying the knot with our hands?
The extracorporeal?
Yes, because the string's outside, our hands right here. There's no need to grab these instruments and try and do it with instruments. They just tie the knot real quick with their hands and then put the knot pusher on and slide it in. When you're inside, intracorporeal, there's no way for your hands to be in there because we're going through all ports. So we have to use instruments then to actually tie the knot and then tighten it down. Make sense? So extracorporeal, knot is tied outside the body, and then the knot pusher is used to push it into place. Intracorporeal, the knot is tied within the body, and we do not need the knot pusher. Usually we're going to put in 2 grasping forceps to do that with. And if once the surgeons are real good with the endo stitch device, they don't even need any extra instruments. They can just use the endo stitch to tie their knot. What do you think we're cutting these sutures with?
So you use the bovie?
Nope. Laparoscopic scissors. Here's some of these some examples of some of these instruments. You've seen some of them in the lab already. Okay. Some of them are traumatic. They got these real heavy kind of teeth to them. They look real rough. Others are atraumatic. So you can grab onto tissue, but not really damage that tissue or tear it up. This one up here, this is, these are both, well, these 3, B, C, and D, are examples of traumatic graspers. A is an atraumatic. Looks like E. This is like a lung clamp. So an atraumatic grasper. This is like a Deval. This one looks kind of like a needle holder. A stone grasper. And an intestinal clamp. You notice how the striations on the clamp itself are vertical rather than horizontal. This makes them non-crushing. So that's why we call these intestinal clamps. We can use this to actually grab the bowel with and not damage it. Shrink. Not that much. Really hate this laptop. It's not very responsive. There we go. But when to inspect? Before we use it. During use, you can watch it on the screen, right? Because once it gets put into the body, it's going to kind of magnify it. So maybe things that we couldn't see, outside of the body or not underneath the scope. Now we might be able to see like maybe a little crack or something like that. And then again, after use, right? Anytime they pull it out of the cannula and hand it back to you, as you're taking it back to them and putting it down on your mayo stand, just kind of give it a once over and make sure it didn't get damaged while it was being used. And then after it gets decontaminated, right, after it gets cleaned, and then again, and then before you reassemble the tray, or as you're reassembling the tray, you're looking over the instruments and making sure they're good to go before you put them in their tray and then get them sterilized. So we're just constantly making sure that they're still functional, that we're not going to have any of that coupling. We're not going to, that they actually open and close, that they lock if they're supposed to lock, all those kinds of things. Oh, what to look for, right? Workability. Does it open and close? Do the tips meet like they're supposed to? Are there any surface defects? Cracks, dents. Is it bent? Things like that. Is it free of all debris and body fluids? Did it get cleaned properly? Right? Is it cannulated? And did the cannulation, did the lumen get cleaned out? And then interoperatively, remember, we're cleaning as we go. That's that point of care cleaning. That's where all cleaning of instruments starts, is on the sterile field. Typically, you're going to get a rack of endoscopic, of your telescopic instruments, your long, skinny stuff. The way that the trays are usually set up is you've got your main tray, which will have your like little small stringer and your pickups, knife handle, that kind of thing. And then sitting within that tray is your rack of endoscopic instruments, and they can be separated from one another. I just usually keep all my endoscopics because it's already set up for you to just kind of grab and pull stuff out that you need. To take all that stuff out of there and try and organize it onto your table or into the pan or something like that, just ends up making more of a mess for you. Plus, they're already laid out for you, so then it takes away time of your setup if you're trying to do all that. You want to place the actual scopes themselves on somewhere with a towel, just to kind of help protect them. You may also have on your field a warming thermos, where we're going to pour warm or hot saline into that thermos, and then you can store your scope in there. The reason we do that is we're trying to get those scopes to be as warm as the patient is, to prevent fogging. That's another way that we can prevent fogging rather than using the anti-fog or the Fred. A lot of times you'll have both the thermos and Fred on your field, just as an extra precaution, because that fogging is going to take away our visualization. Without visualization, we cannot perform surgery. You should use some kind of non-penetrating clamp to secure all your cords down. Most of the drapes now come with like a little Velcro strip, but if it doesn't, make sure you're using something non-penetrating. Make sure you're keeping the right end of the cord, because the two ends of whatever cord you're passing off are usually different from one another. You don't. The one that usually gets confused the most is the light cord. Right, everything else looks very different. The light cord, the two ends, they look different from one another, but it's not just kind of like self-explanatory which one connects to your scope and which one doesn't. Over time, you learn it and you're like, okay, yeah, this is my, this is the end I need to connect to, this is the end that needs to go to the box. But still, every once in a while, I get confused, and it happens where you're just like in a hurry and you throw an end off, and then you grab that to hook it up and you're like, oh no. And now you need to get a whole new cord. Whenever passing instruments, you want to hand them the grip piece, the pistol handle, and have your working end facing down. So the, the handle is facing up so they can grab it with that working tip down, so then they can just move it straight to the cannula and go directly in. And then typically for endoscopy or laparoscopy, arthroscopy procedures, anything under scope, we're going to dim the OR lights in the room or turn them off completely so that the only thing you're focusing on is the monitor. And you're not getting glare and things like that that may be blocking something that you need to see on the picture or something like that. Principles of flexible endoscopy, right? We're trying to look at, passages through in the body, right? Down the esophagus, through the intestine, that kind of thing. Remember, we're always going through like a natural opening. Right? We might even do a flexible cystoscope. That can happen actually in the urologist's office, where they're just going to put a scope into the urethra and look around at the bladder. They're not going to do anything. They're just looking. To give them a better idea, if something needs surgery or not. Right? Typically, they're advanced, kind of carefully, right? You don't want to just take the whole thing and just shove it, into somewhere. Usually, it's like a few millimeters at a time, and then they look around, make sure they're following kind of the natural curvature of things. If you just shove it in there, it may, hit up against the side of, the bowel or something like that, and kind of reflect back off, and then try to come back out the same way you went in. So you have to watch and make sure that you're, turning the camera head the right way and everything, so you can follow that natural path. And you may also take, some biopsies. You put in a special biopsy forceps. It usually looks like a little cup at the end, or like a little ball at the end. And then when it opens up, you just go up against tissue, and it's got little sharp edges on it. And then you bite down on that tissue and kind of tear off a piece of tissue. And then you'll pull the biopsy forceps out. You'll pick out the little piece of tissue and send that on like some Telfer or something for pathology to look at. They usually biopsy areas that look a little patient. If the patient has like a colostomy, yes, we can go through the stoma site with the colonoscope that way too, which would change the positioning of that patient, because typically these patients for endoscopy, when doing like a colonoscopy or something, they'll be in the Sims position, right, with both legs bent, the knees up to like the chest. If we're going through a colostomy site, now the patient will be supine, because we have to go in through a different area. Typically, we're going to follow manufacturer guidelines when cleaning scopes and reprocessing the instruments and things like that. Most light sources and cameras are hand washed because they cannot withstand the heat and moisture of the washer sterilizers. Anything that has a lumen, though, must be completely flushed out. A lot of your robotic instruments, they have multiple lumens within that instrument, and there's multiple port sites that you have to flush. So there's some extra training that goes on with how to clean the robot instruments. Disinfection and sterilization, right? So typically the scopes that we'll use in the operating room, like your arthroscopes, your laparoscopes, your thoracoscopes, cystoscopes, all those kinds of things, those are going to get sterilized. More often than not, be sterilized in the STERAD machine, which is the machine that took the place of the ETO sterilizers, because these instruments cannot handle the heat and pressures of the steam sterilizer. So we have to put them into the STERAD. The disinfection one, goes for the endoscopes or the endoscopy department, like the colonoscopes and things like that, because those items don't need to be sterile. They are considered to be semi-critical items, not critical, because they're entering into like mucosal membrane areas, things like that. They're not actually going into sterile body tissues, right? The esophagus, the large intestine. These are all considered to be dirty areas. We still need to clean them, and they need high level disinfection, which means we're killing all of the bacteria and viruses and the fungus and stuff that may be on them. What we're not doing is killing spores. And we're not putting those scopes into like special containers and things like that. Those scopes, once they're done being disinfected, we just hang them in the cabinet. And the longest that they can hang in that cabinet without being used is 7 days. And after 7 days, then you have to take, if it hasn't been used, you have to take it out and put it back through the high level disinfection process. You have to re-clean it even though it wasn't used, because little microbes and things like that are growing on it. And so now you have to re-clean it just to make sure it's good. Robot. That's what we're going to talk about next, right? Very similar to laparoscopic surgery, only now the surgeon is not scrubbed in at the field. They're over in the surgeon's console, working from there. And typically, you're going to have 1 to 2 people scrubbed in up at the field. The surgical tech and either a PA or first assist. Some other times it's just the tech. So you're the one who's, up at the field. Switching out instruments, all that kind of stuff. It actually gets kind of pretty there. It can be boring at times because you're just sitting there watching on the monitor, not doing everything, occasionally getting up and changing out, a couple instruments or something like that. But at other times, you're up there doing a lot more. You're reaching in with some graspers and pulling out, maybe some needles or, things like that, or putting in the suction irrigator and, just squirting some irrigation around. You're doing a little bit more. So they can be quite fun. The robot uses what's called Cartesian coordinate geometry. All that means is that it's working in 3 dimensions. And the Cartesian is, if you guys remember back from your math class, I know this is not the most entertaining of subjects to talk about right now. But you remember when you were finding the linear equation, right? Y equals mx plus b. I know some of you are having some PTSD right now, and it gave you an ordered pair, right? Like 0, 0 or 0, 8. And that told you the first number was your X number and the second number was your Y number. And that told you where at on the grid. Boom, there's that point. And if you gave it a few more points, now you connect those points into a line. All this means is that we're adding another point because we are now in 3 dimensions. So instead of having an XY, you have an XYZ point. So it could be like 0, 8, 2. So 0 is where you're at on the x-axis, 8 is where you're at on the y-axis, and 2 is where you're at on the z-axis. and all that information is used by the computers in the robot system to tell it where its tip is with regard to that patient's body and how far it can move one way or another without before it reaches its limit. Does that make sense? We're working in 3 dimensions now with the robot rather than 2 dimension. Robots are kind of classified by what kind of movements they can do. Right? Is it a servo robot or a non-servo robot? So a servo robot means that it has sensors throughout, like its tips and the places where it moves, its articulations, right? The places where it has like a little joint that can, kind of change its shape up. It has sensors through all of that. That's constantly sending feedback to the main CPU system, letting it know, okay, this is, you reached its limit of this, or this area has reached its limit. This area still has this much to go. So it knows how much more it can move and manipulate and things like that. Whereas a non-servo robot does not have those sensors. So it cannot give that information to the CPU. So it's a little more limited in what it does. Does that make sense? So, because some robots, like the Da Vinci, these are servo robots. Other ones, like the Mako robot, non-servo. All it is doing is you input the information that you get from that specific patient, from measuring their bone and stuff like that. You enter it, and all it does is give you like a little laser line where you're going to make your cuts. It's not bringing any new information in from that patient. Every bit of information that robot gets, we have to manually input into it. And then it takes that information and gives us something off of that. But it doesn't have any sensors or anything to give us feedback in real time. Some great advantages of robots is that the image that the surgeon is looking at in the surgeon console is in 3 dimensions. Now we can visualize that too on the monitor outside, but we have to wear the 3D glasses and then set the monitor to the 3D image. And it's not as important for us to see that stuff in 3D because we're not the ones who are actively working on it. We're okay seeing it in 2D because we have the understanding of the anatomy. And when we're going in and changing out instruments, or if we're going in to grab something, we're more familiar with working in 2D because of all our laparoscopic and arthroscopic experience. It reduces tremors. Like the surgeon can still have tremors, right? Just because he's using the robot doesn't mean that their tremors go away. But the robot itself is going to compensate for those tremors, and the actual instrument being used isn't going to like shake and twitch and vibrate and all that kind of stuff while the surgeon is doing that in the controls. It'll just stay static. But it does very closely replicate our own articulations, our own movements, right? Because we can do this with our wrists, and then our fingers can go into all kinds of different configurations and things like that, right? We all have a bunch of different joint areas in the fingers. So the instruments match for robot. You can have an instrument that starts out like this, and you can get it to tilt all the way down, just the instrument tip itself, and then you can get the wrist of it to move. And then and while it's moved like that, you can get it to rotate along that area. So you can get a lot of crazy movement out of the robot instruments. Disadvantages: very expensive. The robot itself costs, just those 3 pieces, the tower, the console, and the actual robot arms itself is over $1 million. just a touch over $1 million. But then the instruments themselves have to be replaced, right? A robotic instrument can only be used 10 times. And the way that the system decides that that item has been used is that you actually connected it to one of the arms. And then it registers, okay, this has been used. But it can only be sterilized 15 times. So let's say you have a robot instrument that's in the robot instrument tray that hardly ever gets used. But you're opening that tray for every time you do the robot. So it has to get reprocessed, re-sterilized. After that 15th time, or on the 16th time that it goes to decon, that instrument has to be thrown away, even though it has never been used. So how do you think we get around that? Let's critically think for a little bit. How do you think that you would get around an instrument that hardly ever gets used? You don't want it to keep getting reprocessed to the point where you have to throw it away, but never used it.
I mean, have it in the field, not open it until it's ready to be used.
Yes.
You could field pack it.
That's what I was looking for. There are no trays out there that have just robot instruments in them for that specific purpose. All of your robot instruments you will find in peel pack. So you have to open up each instrument separately. And then you have to be sure of which ones that you're going to use. There's ones that, you can talk to the surgeon before the procedure and then open up the ones that they request. Or it can even be on their preference card, these are the robot instruments that I want. And you go ahead and open those to start with. But that way, you're not having something on your field that's not getting used and just getting thrown away because it has to keep going through that reprocessing. The system is actually pretty good too, where it keeps track of the uses of each instrument, how many times it's been used. So if one, say you did use it 10 times, you actually hooked it up to the arm 10 separate times, then the system recognizes that. But let's say SPD didn't, and they reprocessed it and got it all sterilized and everything, and you get it back in your tray. As soon as you hook it up to the arm, the system will come up and tell you, hey, this one's no good. You can't use this one. And you would just disconnect it, and then you can toss that one into the reprocessing or into the recycling bin, and then get a new one onto the field. But the way to get around it is that you don't even have a tray that has a bunch of different robot instruments in it. You peel pack each one individually. Robotic training, this is what you guys are in the midst of that right now by going to that DaVinci website and doing all the little videos and taking all those little tests and stuff and getting your little certificate. And then your hands-on training is going to come while you guys are in clinical and actually performing the robotic surgeries with a preceptor there to help you and to show you how to drape the robot, how to hook up these instruments, and how to take instruments out, how to dock the robot, and all those kinds of things. So all of the hands-on stuff, and that's why I tell you in the instructions to skip the in-service part, because that comes with you guys being out in clinical. But and you'll do different procedures. Most of the time, what you'll see is lap choles, um, prostate, uh, hysterectomies, and hernias are typically the four main procedures you're going to see done robotically. They're even moving now into doing like bowel resections and stuff that way. Uh, but to see that more mainstream, you're going to see more surgeons coming out of um, residency and stuff, having done more and more of those robotically, is where you'll start to see those really ramp up. Um, but you'll have, the in-service, like I said, you guys are doing while you're on clinical. And while you're doing that, watch what other people do in their roles. Watch what the nurse has to do. Right? The nurse is the one that has to dock the robot. They actually have to bring the one that has all the arms on it close to the sterile field and park it right up next to it. Right. There's others now that there's a bed that is specifically linked to the Da Vinci robot. Because one of the safety issues is that with regular OR beds, once you dock the robot to the cannulas, you cannot move the OR bed. You can't like bring it up, you can't bring it down, you can't airplane, because then you're changing what the computer thinks is the configuration. It has its parameters as far as where these arms can move and stuff like that, and their limitations. And once you start changing where the bed is positioned, that changes those parameters, but the computer of the robot doesn't know that. But now there are beds that talk to the robot, and sensors and diodes and all that stuff inside the robot computer that can say, oh, the bed just went up this far, so okay, now my instruments can only do this much, or the bed dropped, or the bed, the head came up, the head came down, we airplaned to the left or right. Right, that's all going to go into play as far as what those robot arms can now do. Usually, when a facility, didn't have a robot before and has just bought a brand new one, this is where you'll see the rehearsals. We'll have all like unsterile equipment and stuff like that, and we'll actually set up the room like we need to, and then go through and actually practice putting in the trocars, docking the robot, hooking them up, hooking the arms up to the cannulas, hooking up instrumentation, stuff like that, and practicing on mannequins and dummies and stuff like that, so that everybody knows their role, what they're supposed to be doing when we actually go to do these procedures. And these rehearsals are supervised by one of the reps from the Da Vinci company, from Intuitive. They are there with us going, yes, okay, yeah, that's what you're supposed to do here, or be careful of this, or really watch, this is an area that, a lot of things can go wrong, so make sure that you're really paying attention here, stuff like that. And then as far as surgeons go, surgeons will also have like a mentor, somebody who has gone through the robot training and has done quite a number of robot procedures and stuff, watching over a new doctor who's just starting out doing the robot, to kind of help them lessen that learning curve and get them through, kind of some of the humps and obstacles that can come with learning the robot. This is the Mako. So this is the one that they use for total knees, total joints and stuff. You can use the Da Vinci in cardiovascular as well, doing like valve replacements and things like that. Obviously in general surgery, right? If we're taking out a gallbladder, we're repairing a hernia, GYN if we're taking out a uterus, urology for usually the prostate. And I think they've been doing some bladder or cystectomies this way as well. Neuro, typically the robot or the minimally invasive that you'll see in neuro is what's called the Stealth. The Stealth uses CT scans to build like a three-dimensional model of the patient. And then with certain instruments that have sensors on them, you can tell exactly where you are inside that patient's skull while you're working, because the instrument will send the signal to the machine, and then the machine will give you a readout on that 3D model from the CT scan that was created in the computer. It actually shows you on the screen, okay, you're right here inside the patient's skull. You're right next to this nerve, or you're right next to the pituitary gland, or whatever. It'll show you. And that way, and also on that CT scan will show you, you can compare it or to the MRI of where like a tumor is at in the brain. And then you can know exactly what brain tissue to take out. So you're not taking out anything that maybe wasn't affected and then causing a problem later for the patient. So the patient, there's 3 components that come with the robot. You have the patient cart, the surgeon console, and the imaging system. The surgeon console is the thing that the surgeon sits into. It's got the little like binocular place for them to look in and actually see the 3D image, and it's got the controls for the robot arms. It's got a few foot pedals down at the bottom for like cautery and things like that. The patient cart is the part of the robot that's the actual arms that we bring up and dock and connect to the cannulas that are in the patient. And then the imaging system is the thing that's got all the like the CPU, the light source, the camera box, the monitor, all of that stuff. So those are the 3 components to the robot: patient cart, surgeon console, and then your imaging system. Here's some robotic instruments, and these can all articulate or move around at these joints, and they can spin in like 360 degrees. They can bend in, I think, almost 270 degrees, almost facing backwards. And then while they're facing backwards, you can get it to rotate. You can get these things to move in all kinds of different ways. And then you have the same as you do with laparoscopy. Your tips are all doing the same things as your open instruments and as your laparoscopic instruments, because we're still performing the same surgery. We're still doing the same thing. We still need to make that incision. We still need to dissect and expose. We still need to either repair, remove, cut into, whatever. And then we still need to irrigate and close. So the steps are always the same. The instruments are going to look just a little bit different, but they're all going to function. Their tips will all be the same. They're all going to function the same way. That's why they're all still the same shape at the tip. It's because it's the functionality that you're looking for. Now, how you get that instrument into the patient, that's what's going to change its shape on the outside, away from the tip. Because now it's how are we introducing this instrument to the patient? We still need the tip to do its job, but we can change up the look of that instrument in order to get it to where we need to get it. I already talked about decon and reprocessing robots, right? It's very specific to the manufacturer. You have to make sure you flush it completely. All robot instruments go through the ultrasonic cleaner because there's so many nooks and crannies and lumens and all that stuff that there's kind of really no way to get into everything and clean everything. So the ultrasonic cleaner is going to be your best bet. And then they are sustainable enough to go through the washer sterilizer and go through the steam sterilizer. They can withstand that heat and they can be immersed. So all of that is still the same. You just have to make sure you flush those lumens very well. This is kind of your typical setup for a robot. You'll have, this one's a heart procedure. I can tell here by the heart and lung machine that's over here. But your robot will come in on one side. That's docking the robot right here next to him. And then all the arms are connected to the cannulas and working away. Then you have your scrub tech down here with the Mayo stand, usually down near the foot of the patient. The assistant is going to be up across from the robot. The robot is acting as kind of the surgeon, right? And then you have the surgeon's console here, and then your imaging system should be right over here so that the assistant can see it. Because this is what the assistant needs to see in order to see what's going on in here. The surgeon does not need to see this because they're looking at it right here in the console. Now, it would be nice for us to be able to see. We can always move to kind of right here, and maybe we can catch, what's going on. Us watching is what's going to help us anticipate what's coming next. But the surgeon always wants to be in view of the sterile field. They should always be able to just kind of slightly look away from that console and see what's going on with the patient up here on the field. So the surgeon, their role in robotic surgery is they scrub in initially, make the incisions, place the trocars, and then help dock the robot. Get the initial instruments that they want started and everything, all that in, get all that initial stuff out of the way. Once it's time for step 3 of any surgical procedure, right, the meat, where we're going to be actually removing or repairing or anything like that, they break scrub and go over to the surgeon console and work in there. If they do have an assistant on the field, their job is, to suction, irrigate, help, reach into the trocar and manipulate tissue, things like that as the surgeon needs. Our job as the scrub is to remove and replace instruments as they need, to move things around. Say they have a grasper in robot arm number 1, but now they need it in number 3, and it's our job to remove it from the number 1 arm and hook it up to number 3 and get it into the cannula so they can use it. Then the circulator and the coordinator, right? Your circulator is the one who's driving the robot, the patient cart, and docking it next to the OR bed. Right? And then everyone is always watching the patient for patient safety issues. Right? We're making sure that robot arm isn't like trying to pull that cannula out or putting too much tension or something on the skin. That the anesthesia hasn't moved the bed at all those kinds of things, right? The coordinator is the coordinator. We're talking about usually the rep for the Da Vinci robots. They're in the room too, watching, making sure that everything's going smoothly. They're there for kind of a troubleshooter. If something goes wrong, then they can help kind of get us back on track and things like that. These special roles is mainly about safety, patient safety, and communication. We're constantly talking to each other. With the surgeon over at the surgeon console, they may not be able to see any little nuance that's going on with, like, maybe there's a little too much tension on one of the cannulas or something like that, and we have to communicate with them. Hey, we've got a little bit of tension on the cannula that robot arm number 2 is in. Hang on, and because we have to communicate this to them, because we have to get them to stop working before we make any changes to anything. Because it may change up what they're seeing inside. It may cause like a little bump, whatever. They may accidentally cut or use the cautery on something they didn't intend to. So there's always that communication and safety. Right? We're constantly watching, making sure that the patient isn't going to get injured by the robot, or that the robot doesn't come alive and take over the OR. Good. That is it for minimally invasive. Does anybody have any questions on minimally invasive? The bulk of your general surgery procedures will more than likely be laparoscopic.
I got a question as far as the insufflation of the thorax.
Yes.
They're using carbon dioxide now. Is that not absorbed in the lungs and like could be bad for the patient? And
So typically what happens is instead of us insufflating the thoracic cavity, because the thoracic cavity is surrounded by what?
the pleural cavity.
Your rib cage, right? Your bone in your rib cage. So where the abdomen doesn't have any bone, keeping that cavity like contained, right? So when we insufflate that with the CO2, we can actually see it blow up like a balloon. With the lung, we can't really insufflate that tissue because it's going to get up against the bone of the rib cage and not really expand for us. So what we do is we deflate the lung.
That is interesting.
Yeah, so very special process that has to happen with thoracoscopies or any thoracic type surgery is the endotracheal tube that you put down is bifurcated. It's got two ports. So you'll put one down the right bronchus and one actually down the left bronchus. And then they can clamp off whatever side you were working on, and that lung will deflate. And that'll give us the space in the pleural cavity in order to do our work. And then once the case is over, we've got to put in that chest tube. They can reinflate that lung, and then with the chest tube in, keep it inflated.
Cool.
I bet you guys want the code for the quiz. It's in the chat. There's Miss Joyce. Did anyone happen to see if Valeria was in? No, it's all right. I'll check the thing after we're done here. Does have anybody comments, questions, concerns? Kind of went all the way up to 2:30 today. That was good. Yeah, machine is there. I don't think I have any news for you guys. Oh, yes, I do actually. If you guys are not aware, the mask mandate is back in effect, which means we wear masks everywhere on campus, not just in the lab. Remember to wear your eye protection also, though, when you are in the lab. I'm not sure how long this mask mandate is going to last. They canceled the in-person graduation. It'll be virtual again for this time. Hopefully, this all passes over. The Advent Health, I believe, is currently at level black, which means they are not doing elective surgeries. It could mean no students, but fortunately enough for us, our seniors are done and you guys aren't going out until November. So hopefully all of this is cleared up by then. There has not been any word from the hospitals regarding the COVID vaccination, whether it'll be mandatory or not. If they do, add it to the list of immunizations that you should have or whatever, I can't imagine it being any different than the flu vaccine, where you have the right to decline it. But in the way that things have kind of been going, they may make it, yeah, you can deny it, but you can't come to clinical if you do. So we'll see how that goes. So the question is asked, so what happens if we can't do clinicals because of this, right? Like, let's say they've locked us out from clinical. Unfortunately, you have to have, time out there in order to to sit for the test. So what would happen, because it kind of did happen a little bit when they first started this COVID to one of the group of students that was out there. We started your boot camp early. We went ahead and did the 2 weeks worth of boot camp first, giving them time to kind of open it back up to us. If not, we'll just continue with like review stuff, and we'll extend your graduation date is what it would have to happen until you completed your requirements for clinicals so that you get sit for the test. Everybody get the code? All righty. You guys have a good rest of your day. We'll see you tomorrow.